Hi, welcome to Vet Pharma 322. This is Francis Ivan Igot, and together with Jade Aquino, we will be discussing drugs acting on endocrine system. In endocrine pharmacology, a hormone may be defined as a specific chemical synthesized and stored in specialized cells or tissue called endocrine glands. The hormones are released directly in minute quantities into the bloodstream in response to internal needs and changes in external environment to coordinate a multiplicity of metabolic activities that maintain homeostasis within the body. In line with endocrine pharmacology, we have the adrenal corticosteroid. The adrenal cortex produces and releases without storing steroid hormones which influence carbohydrate and electrolyte metabolism and small amount of androgens. The major hormones are subdivided into two classes: the glucocorticoids, whose action are principally on carbohydrate but also protein and fat metabolism, and the mineral corticoids, which are responsible for regulating electrolyte and hence water balance. The relevance of the adrenal cortex to the therapeutics is that hypofunction produces Addison's disease, hyperfunction produces Cushing syndrome, and the glucocorticoids in pharmacological dosage exert powerful gluconeogenic, anti-inflammatory, and immunosuppressive action. And now, I will be discussing the function of corticosteroid. The mineral corticoids act on the kidneys where they enhance the resorption of sodium and chloride, and therefore of water, and increase the rate of loss of hydrions, potassium, phosphate, and calcium. The mechanism of action involves the synthesis of proteins in the target cells, perhaps the sodium carrier itself. Sodium retention, edema, and hypokalemia are features of Cushing's disease or of overdosing with those glucocorticoids which possesses mineral corticoids action. The glucocorticoids influence the carbohydrate and protein metabolism by increasing the gluconeogenesis, in other words, the production of glucose from non-carbohydrate precursor by the deamination of amino acids. This leaves carbohydrate moieties and increases the urinary nitrogen output. Glucocorticoids induce hyperglycemia, which is accompanied by a decreased peripheral uptake or utilization of glucose and resistance to insulin, but liver glycogen stores are nonetheless replenished. Fat stores are also catabolized, as the presence of glucocorticoids favors lipolysis. The glycerol thus made available also contributes to gluconeogenesis. The end effect of long-term steroid administration is muscle wasting and a redistribution of fat, exemplified by the moon face and buffalo hump or Cushing syndrome in man, accompanied by bone thinning due to protein resorption and decrease of calcification. Corticosteroid also sensitize vascular smooth muscle to non-adrenaline and maintain normal capillary permeability and myocardial contractility. Glucocorticoids exert anti-inflammatory and immunosuppressive effect, which are generally regarded as pharmacological effect of glucocorticoids and shared by NSAIDs. These effects are due to the formation and release of an array of mediators. These effects may also be credited to physiological role of glucocorticoids checking the overshoot of body's powerful defense mechanism. Reduction in formation of mediators such as prostaglandins, leukotrienes, platelet activating factor, interleukins, tumor necrosis factor, cell adhesion factor, plasma complement components, nitric oxide, and IgG due to suppression of specific gene transcription also suppresses histamine release from the basophils. Inhibition of vasodilation and formation of edema, inhibition of neutrophil migration and macrophage function, proliferation and action of T helper cells, suppress fibroblast function, reduce production of collagen and glycosaminoglycans, which reduces the progress of chronic inflammatory or healing or repair. Tendency for development of osteoporosis may also occur due to the suppressed action of osteoblasts and increased action of osteoclasts. These above effects are due to interaction of glucocorticoids with intracellular steroid receptors and modification of gene transcription, inducing synthesis or suppression of specific proteins. The biosynthesis of glucocorticoids is inhibited by the mentyrapone, which can be used as a diagnostic test to assess ACTH secretion. Aminoglucotetamide and ketoconazole antifungal agent also inhibited steroidogenesis. These drugs can be used in treating Cushing syndrome. And now, let's proceed to the principle of corticosteroid therapy. Dosage schedule must be according to individual cases and should meet the requirement of replacement to their physiological level. Higher doses results in atrophy of adrenal cortex and permanent hypofunction of the gland. When prolonged therapy is required, small doses are selected. Therapy must also be withdrawn gradually. Corticosteroids do not cure the disease, but give relief due to anti-inflammatory effects. It should be stressed that corticosteroids, other than replacement therapy, are palliative rather than curative. This means that symptoms will reappear unless the primary cause has resolved or been adequately treated when steroid dosing ceases. Corticosteroid therapy should be avoided during active infections, unless compulsory. If used, the microbes may spread over the extensive area which inhibits the natural tissue barrier processes. Use in microbial diseases must be accompanied by high doses of antibiotic. For chronic affections, especially joint pains, conjunctivitis, dermatitis, and pruritus, local application should be preferred because systemic use may cause other effects and atrophy of glands. It should not be used simultaneously with immunization or vaccination schedules. And now, I will be discussing the contraindication for corticosteroid therapy. First, we have the diabetes mellitus, as glucocorticoids may induce insulin resistance. Second, hypertension, as glucocorticoids induce hypertension in animals and human beings through activation of renin-angiotensin system, which reduces the activity of hypotensive kallikrein-kinin system, PGS, EDRF, NO, and more. Third, the renal insufficiency. No glucocorticoid given in large doses is completely devoid of mineralocorticoid activity. Therefore, excessive use may precipitate or exacerbate hypertension and induce hypokalemia. Fourth, the late pregnancy. Late pregnancy is an obvious contraindication, especially for C16 methylated corticosteroids, except in pregnancy toxemia, where recovery often follows abortion. In early pregnancy, fetal abnormality may be found. Fifth, the corneal ulcers. Recent major surgery exemplifies a situation where delayed wound healing could be disastrous. Deep corneal ulceration can readily progress to penetration under steroids. And lastly, the hepatic insufficiency. Glucocorticoids induce a form of micronodular cirrhosis. At the same time, there may be hepatopathy and hepatomegaly. And for the clinical uses of corticosteroids, first, we have ketosis. A major use for glucocorticoids in dairy practice is in treatment of bovine ketosis. The simple disease is characterized by hypoglycemia, elevation of blood ketone concentrations, depressions, loss of appetite, and decrease in milk yield. Despite the presence of normal level of plasma corticosteroids, exogenous glucocorticoids reverse these symptoms. Blood sugar rises due to gluconeogenesis from amino acids and/or reduce the peripheral utilization of glucose. Liver glycogen level increase, and so the previously depressed level of the citric acid cycle intermediates. Blood ketone level returns to normal over a few days. Appetite returns and milk yields pick up after a short delay. And for the drug and doses, we have the betamethasone and dexamethasone. It is administered up to 30 mg/IM. The triamcinolone is a very much effective against ketosis. It is administered 5 ml/IM. And the prednisolone, which is administered 10 ml/IM. Second is pregnancy toxemia in use. Third, stress. A major physiological role for this steroid is that of increasing the ability of the body to resist the stresses of trauma, diseases, environment, and emotions, fatigue, and more. It is argued, therefore, that there is a case for using glucocorticoid as an adjunct to the therapy in any situation in which an element of stress exists. For example, shock, tissue damage, allergy, or toxemia.
Fourth, we have the anti-inflammatory effect. In cattle, it is used for mastitis and lameness. For horses, it is used for lameness due to joint injury or arising from the swollen bursa or tendon sheath, and it also used for conjunctivitis. In dogs, it is used for arthritis, dermatitis, eczema, pruritus, conjunctivitis, iridocyclitis, or acute anterior ovitis. Lastly, it is used for induction of parturition. Administration of a single-dose injection of dexamethasone 10 to 30 mg, betamethasone 20 to 30 mg, or flomethazone 5 to 10 mg to a cow in late pregnancy is followed by parturition within 72 hours. Unfortunately, this induced parturition are accompanied by a very high incidence of retained placenta, and there is an increase in calf mortality to about 15%. For these reasons, the technique remained more of an oddity than a commercially viable practice. It is effective in the ewe after 130 days without placental retention, and this action has been demonstrated in the nanny and mare also. Apart from those mentioned uses, glucocorticoids are also used in physiological replacement therapy, intensive term and shock therapy, immunosuppressive therapy, and neoplasia. And now, for the doses and administration of corticosteroids. First, we have the prednisolone and products with similar activity. For long-acting, it is administered 100 to 200 mg IM daily. For short-acting, 2 to 20 mg IM and initially followed by oral therapy. For dogs, 0.5 to 1 mg per kilogram daily by mouth. And for cats, 1 mg per kilogram daily by mouth. And for the dexamethasone and products with similar activity, in parenteral administration, horses and cattle needs 10 to 30 mg. For foal, calf, sheep, goat, and pig, 2 to 5 mg. For dogs, 0.5 to 2 mg. Cats, 0.25 to 2 mg. And for oral administration, for short-acting, you need 0.25 to 2 mg. These daily doses should be divided whenever possible. Your initial doses may be maximum or near maximum, but once symptoms are controlled, doses should be reduced to the minimum effective. The quoted doses are guidelines figures only and should be in each case be adjusted according to the circumstances. At this point, we're going to discuss the endocrine pancreas. The pancreas, which lies in the loop of the duodenum, contains two vastly different types of glandular tissues. The greater part of the gland is the exocrine and secretes a fluid rich in digestive enzymes via the common bile duct into the small intestine. Dispersed through the mass of the exocrine gland are the islets of Langerhans, whose B cells secrete the stored polypeptide hormone insulin in a rapid response to GI peptide hormones, plasma concentrations of glucose, amino acids or fatty acids, and other local or systemic chemical messengers or drugs. Glucagon is a smaller single-chain polypeptide secreted by the islet of alpha-2 cells, in that it has a glycogenolytic and gluconeogenetic effects. Its actions oppose those of the insulin. The alpha-A1 cells releases somatostatin, the growth hormone releases inhibiting factor found also in the hypothalamus. Glucagon, growth hormone, and insulin are of central importance to the regulation of intermediary metabolism. And for the injection of insulin, generally it is the sterile antidiabetogenic hormone of the pancreas of either the pigs or the ox, appropriately purified. It is a clear, colorless liquid standardized by bioassay to contain 20, 40, or 80 units of activity in each milliliters. Insulin from different sources has a potency in the range of 20 to 80 units per ml. The rate of absorption of insulin and its duration of action depends upon the physical state and the route of injection of the chosen formulation. The complex suspensions such as the protamine zinc insulin and the globin zinc insulin are effective for about 48 hours and 24 hours respectively, but the plain injection is effective for a period of only 8 hours and require injection twice a day. Lenti-insulins, which means the slow insulins, are the preparation of insulins with increased amount of zinc incorporated in their crystals to reduce the solubility of the insulin in the body fluid, and so at the expense of some delay in onset to give a period of action intermediate between that of the plain insulin and the protein complex material. Lenti-insulins are well suited to once daily injections, having an 18 to 24-hour duration of action after SC injection. Furthermore, the hormone MW5700 is a polypeptide composed of two straight cross-linked chain of 21 and 30 residues per chain. There are some minor interspecies sequence variation. The commercial product was the porcine and bovine origin, but is now obtained from genetically engineered Escherichia coli. And for its mechanism of action, after binding to the specific cell membrane located receptors, insulin increases the rate of entry of glucose, amino acids, and potassium ions into the mouse cell. This reverses the hyperglycemia of diabetes mellitus by allowing excess glucose to become intracellular. Inside the cell, protein synthesis is increased and glucose is phosphorylated by ATP and hexokinase and is used to derive energy or for incorporation into glycogen. The storage of carbohydrate is further aided by the inhibition of the action of the enzymes of glycogenolysis. Protein synthesis is aided by the impairment of gluconeogenesis. Insulin also facilitates fat deposition and strongly inhibits lipolysis. Take note that the insulin release is affected by hyperglycemia and in response to amino acids, free fatty acids, ACTH, GH, CAMP, GI peptide hormones, and more. The insulin, growth hormone, and steroid hormones are anabolic in effect. Glucocorticoids, thyroid hormones, glucagon, and catecholamines are catabolic in effect and exert action opposite to those of insulin on glucagon synthesis, nitrogen balance, and deposition of fat. In true diabetes mellitus in dogs, the condition is very much similar to that which occur in man. Hyperglycemia and glycosuria are the dominant clinical features. Ketones are also found in the urine and blood. Sugar present in the blood in large quantities is obtained from various sources. Absorption from the intestine, mobilization of carbohydrate reserves, and breakdown of fat and protein. The metabolism of fat is incomplete and results in the elevation of plasma-free fatty acid concentration, the formation of ketones, and the provision of glycerol. The availability of amino acid is increased, partly from protein catabolism, and give rise to glucose after deamination in the liver. The unproductive drain of carbohydrate, protein, and fat reserves is directly or indirectly responsible for other diagnostic symptoms: increased appetite and thirst, emesis in diarrhea, increased urine production, and a progressive emaciation with marked muscle wasting and lethargy. Bilateral cataract occurs occasionally and wounds are slow to heal. Insulin injections reduce the blood glucose level considerably both by hepatic glycogenesis and by increasing tissue breakdown of sugar releasing energy. Glycosuria ceases when the blood sugar concentrations fall below the renal threshold. Ketone production ceases and the breakdown of proteins and fat is reversed. In acetonemia, in cattle and pregnancy toxemia in sheep, insulin has been used in conjunction with glucose therapy. Sulfonylureas is one of the orally active hypoglycemic agents. These are the hypoglycemic sulfonamides. The mode of action of this drug is a direct stimulation of the secretory activity of the pancreatic B cells plus a sensitization of the target cells to receptors. Sulfonylureas cannot alter the blood glucose concentration in pancreatectomized and juvenile animals, suggesting that sulfonylureas stimulated the pancreas to stimulate insulin synthesis. Indeed, sulfonylureas have become a major therapeutic agent used to treat type 2 diabetes in humans until recently. We have two types of diabetes, the type 1 and type 2. In type 1, insulin-dependent or juvenile-onset diabetes mellitus, there is a B-cell destruction in pancreatic islets. In all type 1 cases, circulating insulin levels are low or very low and patients are more prone to ketosis. This type is less common and has a low degree of genetic predisposition. In type 2, or non-insulin dependent or maturity onset diabetes mellitus, there is no loss or moderate reduction in B cells mass. Insulin in circulation is low, normal, or even high, has a high degree of predisposition, and generally has a late onset or past middle age. Over 90% of the cases are of type 2 diabetes mellitus. Tolbutamide is a short-acting member of the group and the chlorproramide is a long-acting because it is not metabolized. The sulfonylureas have not proved effective in dogs, probably because the diabetes is generally too severe by the time of consultation. Furthermore, the sulfonylureas in another group of oral hypoglycemics, the biguanides, are rather toxic, and their use in man remains under review. Their particular merit is the convenience of the oral administration.